Listen-only mode.
The still practicing physicians now in the town besides Dr. Murphy, who is here also. So a shout out to Ann, or at least the most senior. Dr. Reed was born in Missoula. His dad was a cardiologist here for 30 years before retiring. Dr. Reed attended college at the University of Notre Dame and then medical school at the University of Washington as a WWAMI student. His internal medicine residency and chief residency were at the University of Colorado and general cardiology and interventional cardiology at the University of Michigan. He returned back home to Missoula with his wife and 3 daughters 4.5 years ago. And he currently works as a physician at the International Heart Institute as an interventional cardiologist. And we look forward to his comments. Thanks again. Here you go.
Thanks, George. Well, thanks for coming, everyone. I'm honored to talk about interventional cardiology in 2015. And this will mainly be cases today, just to kind of keep things interesting for people. There's lots of pictures in case you get tired of listening to me talk. I have no disclosures. So the goals of this presentation: to discuss interventional cardiology as a growing and dynamic field, to review some of the latest techniques and procedures in interventional cardiology, and to show some cases. So the first heart cath was in 1929 in Everswald, Germany, by a man named Werner Forstmann, who was a surgical resident, and in spite of his supervisor's objection, self-cathed from the left antecubital vein up to the right atrium and was promptly expelled from residency. He actually walked himself down to the fluoroscopy suite and under fluoro continued to advance the catheter from the left subclavian vein all the way into the right atrium. So he lost his job, was expelled from residency, eventually became disenchanted with surgery, moved into a different small town in remote Germany, and then several years later shared the Nobel Prize. The first coronary angiogram was an accident. In 1958 at the Cleveland Clinic, Mason Soames, who was a congenital cardiologist, was doing a power injection with an aortogram above the aortic valve in a 22-year-old man who had aortic valve disease. And the catheter accidentally fell into the right coronary artery and injected 30 cc's of contrast into the right coronary artery. And it was thought that if you injected contrast directly into a coronary artery that the patients would always fibrillate. But when this patient didn't, Mason Soames realized that it's possible to selectively engage and inject the coronary arteries. And he started developing catheters along with another pioneer named Judkins. And our catheters we still use today, called the Judkins left and the Judkins right catheters. Soames and Judkins developed the first coronary artery catheters. The first angioplasty was not performed in the heart, but was performed in the legs by Charles Dotter at University of Oregon. Somewhat of a maverick, Charles Dotter was really the first person to start thinking about the wires and diagnostic catheters that were used to take pictures could be used as therapy. And he didn't use balloon angioplasty, he used serial dilatation, sort of like we do for esophageal dilatation with these catheters. And the first patient who had angioplasty was an 82-year-old woman who had a gangrenous right foot and refused amputation. She had an angiogram that showed this focal stenosis in the distal right superficial femoral artery. Since she refused amputation, she consented to the angioplasty procedure, and Charles Dotter passed serial catheters through this, and this is the immediate result, and this is the 3-week follow-up angiogram, and her foot healed. She never lost her foot and lived another 3 years. He's famous for saying, if a plumber can do it for pipes, we can do it for blood vessels. The first coronary angioplasty was in 1977. This was performed by Andreas Grunzig. Grunzig was considered the father of interventional cardiology. And he had also done some leg angioplasty in several hundred patients. And the first patient who had coronary angioplasty was a 38-year-old man who had a proximal left anterior descending artery occlusion right here. And it took about 3 hours to perform under conscious sedation, but the patient had angioplasty. And actually 23 years later, he presented with chest pain and had a repeat angiogram in Atlanta when he was 61 years old. And this is the repeat angiogram in Atlanta, and there was maybe 10% residual stenosis. So pretty amazing, the first coronary angioplasty. So in 1977 is when the first angioplasty was. That's also when Star Wars came out. And for many of you, you're looking forward to the next episode 7 of Star Wars is coming out in a few days, The Force Awakens. Also in 1977, that was the year I was born, so between angioplasty and Star Wars, a pretty important year for me personally. The first in interventional cardiology in 1977 was basically angioplasty with balloon on a stick. So there was a fixed wire technique where the wires weren't really steerable, they were attached to the balloon and just had to sort of penetrate a lesion, and it was very crude, and the balloon was inflated. They also had these perfusion balloons where with the balloon inflated, there was a fenestration in the balloon so blood flow can still get downstream from the balloon occlusion that could be left up for several minutes. These were only large vessels were treated, proximal LAD, proximal large right coronary artery. The first sheath and guide was 10 French and 9 French respectively. Now we can do angioplasty through a 5 French guide. It took 3 to 4 hours to perform. The success rate was only 63%. There was almost a 25% conversion rate to urgent CABG, and so it was routine to have CT surgery and anesthesia on standby for every angioplasty. To put that in perspective, just at St. Pat's, we do about 600 angioplasties a year. So imagine Dr. Long on standby 600 times a year for every angioplasty. Around the same time as the first angioplasty took place, Dr. George Reed moved to Montana and opened up an office. This is an advertisement from 1978 for George H. Reed, my dad, who's in the back row today joining us. So one of the pioneers in Montana. And here you can see an old school photograph of George Reed when he still had brown hair, and he's speaking to a colleague using this antiquated equipment that looks like something out of 2001 Space Odyssey. So this is sort of a memorabilia from the past. A timeline since 1977 in interventional cardiology, things moved pretty rapidly. So the first angioplasties in 1977. In 1982, there was a major advance in the equipment that was used, smaller sheaths and guides, and steerable guide wires. So instead of just having this fixed balloon with a wire on the tip that you just kind of spun and forced in there, you now had guide wires that could be steered down further into the coronary artery to allow more support and more deliverability of the angioplasty balloon. In 1982, there also was the first angioplasty in Montana by Dr. Reed, Dr. Wilson, and I think Leonard Wilson was also involved in the first angioplasties. 1985 was a sad year for interventional cardiology. Several of the pioneers, Grunsig, Soanes, Judkins, and Daughter, all died within months of each other. Some of them tragically. Grunson had a plane accident, and the very next day he was scheduled to meet with a doctor named Paul Maas. And Paul Maas eventually developed the Paul Maas shot stent. The Paul Maas shot stent was the first stent that was used in coronary angioplasty, and the term angioplasty was changed to percutaneous coronary intervention, which is the term we use today, PCI. That was first approved by the FDA in 1994. It's amazing that we've only been using coronary stents since 1994. In 2003, the first drug-eluting stent, the Cypher drug-eluting stent by Johnson & Johnson, was FDA approved. In 2004, the second drug-eluting stent by Boston Scientific, the Taxis drug-eluting stent, was approved. And multiple trials showing the superiority of drug-eluting stents compared to bare metal stents and restenosis were then published. And then in 2007, the Courage trial was published, and I put this on there because I think it really was a paradigm shift in how we approach patients with coronary artery disease. The Courage trial was a trial that compared optimal medical therapy with PCI in patients with stable angina. And the important take-home message is that this is in patients with stable angina, not with unstable or acute coronary syndromes. And there was no difference in survival using medical therapy or percutaneous coronary intervention. So this was a paradigm shift from what many believed was a life-saving benefit of percutaneous coronary intervention in stable coronary disease. The other point worth mentioning is the difference in failure rate of the original angioplasty and a contemporary drug-coated stents. So in 1982, when angioplasty was first being performed in Montana, plain old balloon angioplasty had a 40% significant restenosis rate. And that usually happened in the first few months. Compare that to a 5% restenosis rate of the 2015 drug-eluting stents. In addition, acute vessel closure with plain old balloon angioplasty was 10%. And that occurred often after the patient had left the lab several hours later when the cardiologist was home asleep in bed. Contemporary drug-eluting stents, the Xience stent is probably the best stent on the market, has a less than 1% acute failure rate or acute closure rate. So a major difference in the failure rate of these stents and these balloons has really changed the way that we've thought about angioplasty and percutaneous coronary intervention to the point where the majority of our elective percutaneous coronary interventions at this hospital are sent home the same day. And the majority of our ST elevation MIs go to the floor instead of the ICU and go home within a couple of days. Because of the literature that's published comparing medical therapy and stenting, because of the improved quality of the stents and less restenosis, the kind of patients that we're treating in interventional cardiologists is changing just in my short career. There's less restenosis, there's less stable angina. We're treating more and more acute coronary syndrome. 10 years ago, the majority of interventions were in stable angina. Now, the vast majority of patients have acute coronary syndrome, either a MI or accelerated stuttering unstable angina. We're treating more complex patients with high-risk PCI. We're also treating more elderly patients with more and more comorbidities. And so the nature of intervention has changed just in the last decade. And that brings up sort of the bulk of the talk and the starting point for some of the cases I want to show you guys. So interventional cardiology in 1977 was mainly angioplasty of the coronary arteries, but interventional cardiology in 2015 really has multiple broad categories of subspecialties. And coronary intervention is still sort of the foundation of interventional cardiology and the mainstay. This includes both basic and complex coronary intervention. I'll show you some cases. Peripheral artery intervention, including lower extremity intervention, mesenteric artery intervention, and carotid artery stenting. Miscellaneous structural heart, this is really a broad category. It includes multiple types of closure, including congenital heart defects like atrial septal defect closure, ventricular septal defect closure, and we're moving into left atrial appendage closure, which is a procedure that we're just starting to perform in this hospital. Alcohol septal ablation of patients with hypertrophic cardiomyopathy, as well as multiple other miscellaneous structural heart procedures. It's a whole other category of interventional cardiology. And then an area that's near and dear to my heart is valvular intervention. In the last few years, valvular intervention has really revolutionized interventional cardiology, and I think cardiology in general, particularly with transcatheter aortic valve replacement and percutaneous repair of the mitral valve with a mitral clip. So let's start with coronary intervention in 2015. I want to just sidetrack a little bit and talk about transradial PCI. So this is a preferred technique by some cardiologists around the world. There has been in the last decade a worldwide transition towards more transradial PCI. The USA was initially slow to adopt this technique, but now nearly 20% of percutaneous coronary interventions are performed through the wrist instead of through the groin. There are some practical and clinical advantages to the radial approach, which I'll talk about, but there's also some limitations. So the practical advantages to transradial PCI, there are fewer vascular complications and less access site bleeding. You can imagine if you bleed from the groin, particularly if it's a higher stick, you can bleed into your pelvis and they can even go undetected for hours. Patients can have life-threatening retroperitoneal bleeding from a femoral access stick, particularly if they're on multiple anticoagulants. From the wrist, on the other hand, if you happen to bleed and you get a little walnut-sized hematoma, the patient themselves can hold pressure. It's easy to compress. So there is less access site bleeding with transradial PCI. Patient comfort is a major advantage, particularly if patients have orthopedic problems, orthopnea, major obesity, trouble laying on their back. The radial is a nice option for these particular patients. It also allows early patient mobility. There's advertisements where patients are sitting there sipping a cappuccino up in bed saying, I just had a heart cath 20 minutes earlier. So, you know, but there really is, they can get up right away and use the bathroom, so it's kind of a nice advantage. As I mentioned, there are some patients who are really poor transfemoral PCI candidates. If you have morbid obesity or severe iliofemoral peripheral artery disease or orthopedic limitations. Some of these practical advantages have translated to real outcomes in the registry of which we are a part at St. Pat's. The procedural success rate with radial PCI is equivalent to femoral PCI. Vascular complications and bleeding complications are significantly reduced. And fluoro time, unfortunately, is higher with transradial PCI. A couple minutes probably doesn't matter to the patient, but over a career, if you're doing thousands of PCIs, a couple minutes per case may make a major difference for the operator and for the staff. So as I mentioned earlier, in the U.S., transradial PCI in 2007 was 1%, and now it's actually closer to 20% in 2015. So what are the limitations? Well, if you're in a hurry, you may not want to go through the wrist. So we get graded on our door to balloon time, our door to device time. If it takes an extra couple minutes through the wrist, then you may have to sacrifice some of your outcomes in terms of door to balloon time or door to device time. Me personally, if there's a patient who's stable and has an ST elevation MI, I feel comfortable going through the wrist, but if they're crashing, they're really unstable, their blood pressure is low, I don't waste time with the wrist, tend to go through the groin. Radiation exposure is an issue, as I mentioned, I think not so much to the patient, but to the operator and staff over a long period of time. If you need hemodynamic support, or you need a temporary transvenous pacemaker and you happen to be in the wrist, then you got to move to the groin, and it can, you know, in some of these patients, seconds really matter. Some patients have small wrists, and small wrists usually means small radial arteries, and you can get lots of vasospasm in the radial artery. Patients can have tortuosity in their subclavian artery or their innominate artery. It can make it difficult to pass the equipment. Guide support is an issue. Most of the guides that we use for PCI are designed to go through the groin, but through the wrist, they may not give you the same support. If patients have bypass grafts, like a left internal mammary artery coming off the left arm, and you're doing a transradial PCI from the right arm, you got to come down to the aorta and back up in the subclavian, can be really difficult. And then, you know, if you're a provider and you've been doing transfemoral PCI for a decade or more, learning a new technique when you're really good and really skilled at a transfemoral is definitely a barrier. I think it takes several hundred transradial PCIs until you're comfortable. So this is the cath lab setup. Here you have an invasive monitor where we real-time measure the pressure and the waveform of the artery. We have a EKG here. The images are here. Here's the image intensifier that rotates over the patient during the procedure. There's a monitoring room with staff. The doctor and an assistant stands here, and here we can control some of the equipment, tend to get access either through the groin or through the wrist, and then proceed to coronary angiogram. This is the equipment that's used for access. You have lidocaine and then an angiocath access. There's a glide wire that I didn't show, and then there's a sheath through which we can introduce our equipment. I'll just show you a quick example of getting access from the wrist. You can see that it really doesn't take that much extra time. So the angiocath is stuck through and through the radial artery, actually through the back wall using the original Seldinger technique, and it doesn't seem to increase bleeding in the wrist. You pull the angiocath back until you have a squirt of blood, and this little glide wire slides in. This is the patient's wrist, by the way. And then over this wire, we're able to advance our introducer sheath with a dilator. And once the sheath is in, the dilator and the wire come out. And then we give verapamil to help minimize spasm. That's verapamil being injected. And that's it. So pretty straightforward. We'll go back to our talk here. So time for a couple of cases. So the first case I wanted to show is a 67-year-old man who presented with chest pain, crushing for 2 hours. His electrocardiogram showed an acute inferior ST elevation MI. He received aspirin and clopidogrel and IV heparin per our protocol. He initially was in Hamilton and was transferred via MedStar. I see a couple of MedStar guys here for primary PCI. And this is his coronary angiogram. We went through the wrist. And this is the right coronary artery. The arrow points out the occlusion in the mid-right coronary artery with no flow past the occlusion. So that's why he's having so much pain and EKG changes. A wire was passed through the occlusion and manual thrombectomy was performed. This was a couple of years ago, I think, before manual thrombectomy fell out of favor. And here you can still see there's a residual lesion after sucking out some of the clot. It's a long lesion, so a long stent was implanted. I think this is like a 3.5 by 33 millimeter drug-coated stent. And there's a nice result with nice flow in the right coronary artery. Patient felt much better. And this can all be performed through the wrist without much delay in door-to-balloon time. Second case is a 61-year-old man who has acute chest pain, presented to Polson with anterior ST elevation MI, got IV heparin, clopidogrel, aspirin, as well as full-dose fibrinolysis with TPA. The TPA did not work. His repeat EKG 30 minutes later showed persistent ST elevation. He had ongoing chest pain, so he was transferred again via MedStar or LifeFlight, one of these guys, for rescue PCI. So if you look at all these blood thinners that this patient has received, aspirin and clopidogrel and heparin and lytics, this is an ideal scenario, if you can, to go through the wrist and really minimize the chance of major vascular bleeding. So you can see in this patient, he has 100% occlusion of his mid-LAD that's outlined by that orange arrow. This vessel was wired, and there's a little bit of haziness just downstream from an old stent here. Little haziness there. I think we may have done a low pressure balloon angioplasty. And then a stent was implanted over the lesion and he got a nice result. And this is all done through the wrist, so you don't have to worry about is he going to bleed into his groin, is he going to bleed into his retroperitoneal space. So there's really an advantage of transradial PCI. It's harder to do. It takes, I think, a lot more effort. It takes sometimes a lot more troubleshooting. So if you're in a hurry, it's not a good choice. There are practical advantages, but you really need to be experienced with transradial PCI and aware of troubleshooting techniques in order to pull it off successfully and consistently. So I want to talk more about complex high-risk intervention. I was talking with Dr. Maddox the other day. It just seems like anymore we're not treating simple, straightforward lesions that often. When we have a type A, meaning an easy lesion in a branch artery, we call each other into the lab and say, look at this is so unusual. It seems like we're treating a lot of complex high-risk patients, surgery turndowns or acute coronary syndrome in elderly patients. Now, this case is that of an 80-year-old man who had prior bypass surgery more than 10 years ago, including a left internal mammary artery off of his subclavian to the diagonal. He was an inpatient who had a AAA open repair that was complicated by postoperative bleeding from the repair. He developed ongoing chest pain in spite of a nitroglycerin drip at 50 mics per minute and a troponin of 30. He had subtle ST elevation in his anterior leads that did not quite meet criteria for STEMI. And as he's getting wheeled to the lab, oh, by the way, he has an ejection fraction of 30%, severely reduced heart pump function, and at least moderate aortic stenosis. So this is a really high-risk scenario, reduced ejection fraction in an elderly patient who's bleeding already, and you have to access the left internal mammary artery, and he's got a fresh graft repair in his aorta. So we decided to go through the left wrist in this patient in order to access the left internal mammary artery and avoid the AAA repair altogether. This patient had a vein graft to his left anterior descending artery that had a severe lesion pointed out by that arrow in the proximal vein graft, 80 or 90% lesion in the proximal vein graft, and working from the wrist, we worked over this wire called a spider filter, and you can see the filter downstream. And this filter wire is designed to catch debris that might be knocked loose when you implant a stent in a degenerated old vein graft. And you tend to oversize this spider wire by at least 1 millimeter. So if we think the vessel is 4 millimeters, we'd implant a 5 millimeter basket. And working over that wire, you can see the stent being implanted in this patient. I think it was like a 3/5/15 stent or something. And then he got a nice result and he did okay. So these are the kind of complex interventions we're encountering. This is another patient who was just transferred to us last week, a 74-year-old woman who has a non-ST elevation MI. She had flash pulmonary edema and polymorphic and presumed ischemic ventricular tachycardia. She presented Helena and had ejection fraction of 35%. An angiogram there showed severe distal left main coronary artery disease, 90%. She also had significant COPD and deconditioning and generally soft appearance, as well as chronic kidney disease, and she was felt to be a very high risk patient for coronary artery bypass grafting, and she was then referred for high risk percutaneous coronary intervention. So here you can see this patient. This is an 8 French guide. It's a bigger guide than we normally use, but she has a severe lesion in her distal left main coronary artery, denoted by that arrow, as well as a severe angulated lesion in the ostium of the left anterior descending artery. So this is a complex situation. If you try and wire the LAD and you fail and you close it, this patient probably wouldn't survive. So we did this procedure with a support device called a balloon pump. The balloon pump is inserted in the descending aorta, and it inflates during diastole and it deflates during systole. So the idea is that it improves coronary perfusion during diastole and then it decreases afterload during systole. And this patient had 2 wires placed, one in the left circumflex to protect it and one in the LAD, and then a large stent. I think it was a 3.0 by 15 millimeter stent that was then flared up to almost 4.0 millimeters in the left main. And she had a nice result and did okay. So these are the kind of procedures that we're seeing now. The type A lesions, this is the LAD in that same patient. She had some tubular stenosis in the mid-LAD, but nice flow at the end of the case. These are the kind of procedures we're seeing. It seems like they're getting more and more complex. Patients are requiring more and more support and risk. There's a new device that I wanted to mention we're going to have here probably in the next few weeks called the Impella device. It's a hemodynamic support device that is inserted from the groin and sits across the aortic valve. It's called an axial flow support device. There's a propeller inside, they call it an impeller, inside this sheath, and it rotates at 51,000 RPMs and sucks blood out of the left ventricle and then squirts it back into the aorta, and it maintains a mean arterial pressure of 60. It can pump at up to 2.5 liters per minute in the smallest device to 3.5 liters per minute, and then there's a large device that can even give 5 liters per minute for full hemodynamic support. Also of note, if patients have a massive PE or a massive right ventricular infarct, there's a right-sided support device as well. So this will be a nice augment to high-risk PCI as well as hemodynamic support that we'll have probably in the next couple of weeks. I want to shift gears a little bit towards peripheral artery intervention. Peripheral artery intervention is actually preceded coronary intervention. As I mentioned, the first angioplasty was done in the periphery, and we'll show a couple cases of this. So the first case is a 78-year-old woman who has severe hypertension on 5 maximum drugs. She was at her hairdresser and had some chest pressure and headache and felt uncomfortable and had a blood pressure in the emergency room of 240 over 110 in spite of compliance with all 5 of these drugs. She had a renal artery duplex ultrasound that showed elevated velocity across the right renal artery, and this was consistent with right renal artery stenosis. She did have a significant lesion in the proximal right renal artery, maybe 75–80% proximal right renal artery stenosis, and underwent stenting with a large stent to improve blood flow to the right kidney. Now, renal artery stenting has fallen out of favor. There's been a couple randomized trials that have not really shown benefit in all comers with refractory hypertension and renal artery stenosis. But it still is considered in patients who have truly refractory renal artery hypertension, like this lady, 5 drugs, severely elevated blood pressure, renal artery stenosis. I still would consider implanting a stent. In fact, this lady was able to wean 2 of her blood pressure drugs after her renal artery stent. So there may still be some patients in whom this procedure works. Next case is a 70-year-old man who has insulin-dependent diabetes. He's a former smoker, and he has 6 months of postprandial pain in his abdomen and cramping, also food aversion and a 30-pound weight loss. He had an extensive workup that included an EGD, a right upper quadrant ultrasound, a gastric emptying study, all of which were normal. And I think it was Dr. Casey Harbine who thought, well, maybe this patient has mesenteric ischemia, and ended up ordering a CT scan of the abdomen that showed a severe lesion in the superior mesenteric artery as well as the inferior mesenteric artery. And the general rule of thumb is that patients really need to have 2 of their gut arteries compromised in order to develop mesenteric ischemia, the celiac, the SMA, or the IMA. In this particular patient, both the IMA and the SMA were compromised. This is an image of the superior mesenteric artery. There's a severe 90% stenosis in the proximal superior mesenteric artery. This patient underwent stenting with a large, I think it's 7 by 15 millimeter stent, with a nice result in improved flow to the superior mesenteric artery. And I kid you not, after the procedure, this patient ordered a giant breakfast of waffle and bacon and eggs and had no pain. And he came back to clinic a couple months later and had gained 20 pounds and had absolutely no postprandial pain. So it's pretty neat diagnosis. Next case is a 79-year-old woman who's a rancher, or actually this is a man. It's a man. He's a rancher and a former smoker. He had severe bilateral buttock, thigh, and calf claudication at 50 feet when he was walking across his property inspecting the fences. He had abnormal ankle brachial indices with exercise. Something that's worth noting is that if you strongly suspect peripheral artery disease and claudication, and you have a resting ABI, and the resting ABI is normal, you still want to consider getting an exercise ABI, because particular iliac disease, you might have a normal resting ABI, and it's not until after they exercise that the ABI will fall. And his ABIs were pretty normal at rest, but with exercise dropped to a severe degree. And this patient had bilateral common iliac stenosis on the right. Here's a severe calcified lesion in the right common iliac, and on the left, a severe calcified lesion in the left common iliac. This patient was almost 80 years old, not a great surgical candidate, underwent percutaneous treatment. These are balloon expandable stents. These are both large, I think 9 millimeter balloon expandable stents. The reason you use balloon expandable in this position is that you can position your stents perfectly. Sometimes the self-expanding stents will jump. This is a technique called kissing balloon angioplasty, or kissing stent angioplasty. So both the stents are deployed at the exact same time so that you don't fold over and compromise blood flow to either leg. And he had a nice result. There's still maybe 10% residual stenosis on the right, but nice flow to his legs, and he felt great after this. So peripheral artery intervention can really help improve patients' quality of life. We had a patient actually who had ordered a motorized wheelchair because she was so disabled from bilateral common iliac stenosis, and finally her regular doctor made the diagnosis. She had bilateral iliac artery stenting, and she was hiking the M, literally. So you really can make a difference if you make this diagnosis. I think it's often underappreciated. Shifting gears again to valvular intervention, I think we have lots of time left. I wanted to talk about specifically transcatheter aortic valve replacement. We've been doing this for almost 3 years at St. Patrick's Hospital, and we're approaching 200 cases. It's really important because the population at risk for aortic stenosis is increasing day by day. Right now there are 40 million people in the U.S. over the age of 65, and 7% of them have severe aortic stenosis. In 2020, the population between the ages of 65 and 74 is thought to increase by 74% compared to 1990. And this chart just illustrates the massive baby boom effect that we're seeing. And so we're seeing more aortic stenosis as well. Why does it matter? Well, the aortic stenosis natural history is dismal. So this is a classic diagram by Eugene Brunwald where you can see that you can live with aortic stenosis. Survival is on the left and time is on the right. You can live with aortic stenosis for a long time, even severe aortic stenosis. But once you develop severe symptoms like angina, syncope, or congestive heart failure, your prognosis drops off a cliff. In fact, if you have shortness of breath or symptoms of congestive heart failure with severe aortic stenosis, the 2-year survival is 50% on average. If you have severe inoperable aortic stenosis, your survival is dismal. Over here we can see severe inoperable aortic stenosis, 5-year survival, compared to metastatic cancer, breast, lung, colorectal, prostate. This is a dismal prognosis if you have severe inoperable aortic stenosis. So what's the treatment? Aortic valve replacement. When patients are severe and symptomatic, they need a mechanical fix. There's no medications that treat aortic stenosis. It's a mechanical problem that needs a mechanical solution. And traditionally this meant open heart surgery. So the traditional landscape for all patients with severe aortic stenosis is if you're low risk or high risk, you get surgical aortic valve replacement if you were a candidate. If you weren't a candidate, you were too high risk or inoperable, receive medical treatment. But the landscape has changed, and now for patients who are high risk or inoperable, there's a new option called TAVR, which is transcatheter aortic valve replacement. This is just a cartoon of the TAVR. TAVR is a procedure where we implant an aortic valve through the groin. So we don't take the old valve out, we just smash it out of the way with either a self-expanding or a balloon expanding valve. This is the most common valve implanted worldwide is the SAPIEN valve. This is actually the second generation of the SAPIEN valve. You can see that the leaflets themselves are actually made out of the same tissue that the surgical valves are made, bovine pericardial tissue. We have these cobalt chromium struts. The important thing to notice is that there's gaps between these struts. So these gaps are really crucial in anchoring the valve. There's stalactites of calcium on the patient's natural annulus. When the valve is implanted, we rely on the space between those struts to anchor this valve inside the patient's native annulus. We have different sizes of this valve ranging from 23 millimeters to 29 millimeters in diameter. And we like to oversize the valve by at least a couple percent. This is just an animation, kind of an older video, but it gives you an idea of a transfemoral TAVR. Some people say TAVI. And this particular patient has severely narrowed aortic valve with restricted leaflets, not opening very well, heavily calcified. He was a transfemoral candidate, and so a wire was passed from the groin across the aortic valve. The patient had a balloon angioplasty where we just inflate a balloon to crack the valve and create space for delivering our transcatheter valve. A big sheath is inserted through the groin. It's a giant sheath because it's a pretty bulky valve. And then over the wire, the valve is advanced on this valve delivery system. Across the native valve, the patient is rapidly paced and the valve is deployed. We pace the patient at 180 beats per minute, and the reason to do that is essentially to create cardiac standstill so this valve doesn't embolize during the procedure. And here you can see that the valve leaflets are moving great. The old valve is smashed out of the way and the coronary arteries are not compromised. So this guy got a perfect result. And that takes us to our next case. So this is an 82-year-old man who has severe aortic stenosis. He has class 3 heart failure with an ejection fraction of 50%. He's had 2 prior bypass surgeries, both in 1985, and as well as percutaneous coronary intervention. He also has multiple sclerosis that really limits his mobility and was felt to be a major impediment to his recovery from redo open heart surgery. He had an echocardiogram that showed a heavily calcified aortic valve. Here you can see the gradient across his aortic valve. The mean gradient was 45 millimeters of mercury. The peak velocity was 426 centimeters per second, and the valve area is 0.53. So these are all severe markers for aortic stenosis. Coronary angiogram didn't show any severe blockages in his grafts or his native arteries. He underwent a CT scan of his chest, so Dr. Brake and Dr. Jaley are both instrumental in measuring the valve annulus in these patients. So the valve size is really crucial in us picking the right transcatheter valve. We also look at the height of the coronary artery above the annulus. We look at the width of the sinus of Valsalva and try and predict whether this patient is a candidate for a transcatheter valve. So the CT is really key. Also on the CT, these patients undergo CT angiogram of the leg arteries to see if they're a candidate for a transfemoral approach. If we can implant this valve through the groin, it makes a major difference in these patients' recovery after the transcatheter valve. If they're not candidates, then we can implant the valve through the apex. We, the surgeons, Dr. Long or Dr. Maxwell, can implant the valve through the apex of the heart. Luckily, this patient had large enough iliacs, and he had a surgical cut down onto his femoral artery, and a transcatheter valve was inserted up and around the aortic arch. And here you can see the patient's heart is being rapidly paced at 180 beats per minute, and the balloon is expanded that deploys this balloon expandable valve, and we count to 4 Mississippi with the balloon up. It's also always very disconcerting because there's no blood flow to the patient's heart during the deployment of the valve. I'll just show you that again. So we're rapid pacing the heart. Here's a pigtail in the aorta. We're injecting to make sure the valve is in the right position, and then we inflate the balloon for 4 seconds. The valve is deployed. After 4 seconds, we deflate the balloon, turn off the rapid pacemaker. And here you see we pulled everything out, the wire and everything, and we take an aortogram, and there's no compromise to the coronary arteries, and there's no leakage around this particular valve. So this was a nice implant. It turns out that this was the very first man in Montana to receive a transcatheter valve. And this was almost 3 years ago. He's still alive and doing really well. One of the problems with the early generations of transcatheter valves is that you can imagine if patients have these little stalactites around the valve, you can have these things called gutters around this valve because we're not suturing this valve in place, so you can have leakage around the valve. And if you have significant leakage around the valve called paravalvular leak, that's correlated with worse outcomes and increased mortality. So the latest derivation of FDA-approved valves, including the latest SAPIEN valve, have made adjustments to try and compensate for this paravalvular leak. The SAPIEN 3 valve is the valve that we implant most commonly now in this hospital. It has a skirt. The skirt is designed to minimize the risk of paravalvular leak, and in fact it does. It works really well at minimizing the risk of paravalvular leak. The other advantage of this valve is it's much smaller in profile, so we're able to implant through small iliac arteries, whereas in the past we would not have been able to implant. There's another valve that's made by Medtronic that also has the advantage that it's low profile, but it's also repositional. So if you're halfway through the deployment and you decide, oh, this valve is too small or it's not in the right place, you can pull it back into the sheath and reposition the valve completely. So major advances in the latest derivation of these valves. And that takes me to the next case. This was a more contemporary example of what we're doing in the cath lab with these transcatheter valves. This is a 79-year-old woman who had class 3 heart failure and angina. She has critical aortic stenosis in a bicuspid valve. So the bicuspid valves only have 2 leaflets instead of 3, and the orifice is often quite eccentric. So you worry more about paravalvular leak with bicuspid valves because the orifice is abnormal. This patient was considered high risk for a surgical aortic valve replacement due to COPD and chronic steroid use. She had very small iliac arteries, so this is worth noting. 5.5 millimeters is small. We would not have been able to treat this patient with the first generation of transcatheter valve through the groin. But with the SAPIEN 3 valve, we were, as I'll show you. This is her echocardiogram. Here's the left ventricle, left atrium. The mitral valve is here. And this is the aortic valve. It's heavily calcified and bicuspid and relatively immobile. Her peak velocity across the valve was 524 centimeters per second, mean gradient of 62, and valve area of 0.67. So these are all critical measurements. She has critical aortic stenosis with symptoms. We were able to go through the groin, and here's a balloon angioplasty across the valve. One of the things that's worth noting also about this patient is this block of black. So this is heavy left ventricular outflow tract calcium, and that increases the risk of rupture when we implant these valves. And the other thing it increases is the risk of leakage. This is one of those stalactites that we worry about. Patients may have leakage. So implanting a SAPIEN 3 valve with this skirt around it will help minimize the risk of leakage in this patient. And this is a SAPIEN 3 valve, a 23 millimeter valve. We're rapid pacing the heart and then going up nice and slow and counting to 4 Mississippi with the valve being deployed. And then deflating the balloon. And she has a really nice result. So there's no compromise to the coronary arteries. There's no leakage, no paravalvular leak in spite of this heavy left ventricular outflow tract calcium, in spite of a bicuspid valve, and there's no damage to her iliac artery. So, we're able to implant this valve in a small iliac artery with a bicuspid valve and heavy left ventricular outflow tract calcium, and this patient went home the next day. So major advances are happening in real time with transcatheter valve replacement. I don't want to inundate you with data, but I just wanted to show a couple key slides about the outcomes with transcatheter valve. This is the original trial, the partner trial that compared patients who were not candidates for surgery to transcatheter aortic valve replacement. And at 2 years, you had an absolute reduction of death of 25%. So that's an absolute risk reduction. That's a major, major change in outcome. That translates to a number needed to treat of 4. You treat 4 patients with this valve, you save 1 life. If you think about landmark trials in medicine like early goal-directed therapy for sepsis, for example, the number needed to treat is 7 to save 1 life. It's not often that we see major trials where you see a number needed to treat to 4 to reduce mortality. But a lot of our patients are elderly patients. Their main focus is not necessarily living longer. Their main focus is improving their quality of life. So in the inoperable cohort in this particular trial, it's also worth noting that days alive outside of the hospital were doubled with TAVR compared to standard therapy at 2 years, 699 versus 355. So it's not just mortality, also impacting quality of life in these patients. What about compared to surgery? In the original PARTNER trial, high-risk aortic valve replacement, so patients who are considered to have an 8% risk or more of death with surgery versus transcatheter valve at 2 years, no difference, or 3 years rather, no difference in survival, transcatheter valve versus high-risk surgery. And in fact, in the self-expanding valve, the core valve trial at 1 year, and this translated also at 2 years, there was a survival benefit for transcatheter valve replacement compared to surgery in high-risk patients. So just a couple final thoughts. It's really revolutionized the care of aortic valve disease. TAVR is obviously a complicated procedure. There's multiple disciplines involved between radiology, anesthesia, imaging, cardiology, cardiac surgery, interventional cardiology, coordinating with the families. It requires a well-orchestrated team, a well-oiled machine. The use of TAVR technology will continue to expand. I think this is true. We'll see more and more patients with aortic stenosis. Eventually, this technology will, I expect, be offered to intermediate risk patients. There's 2 large trials in intermediate risk patients, so I think that in the next year or 2 we'll see the evidence supporting this device in intermediate risk patients as well. It's already FDA approved for valve-in-valve. For patients who had a previously implanted surgical valve, we can now implant a TAVR valve-in-valve. Bicuspid aortic valve, I think we do routinely now. And mitral valve replacement through the apex of the heart or through a transeptal puncture, we will see down the road as well. We're not quite there yet. And as the generation of the valve get better, we'll see fewer and fewer complications. We'll be able to treat more and more people. I wanted to talk also about percutaneous mitral valve repair. This is another interventional cardiology procedure that is performed in the cath lab. We're very fortunate in this hospital that this procedure has been performed for over 10 years by Dr. Maddox, and he's mentored me in this procedure. And since the valve has been commercially, or this repair has been commercially approved for degenerative mitral regurgitation, we've seen an explosion of referrals for mitral valve repair percutaneously. I think in the last year and a half we've implanted 30 or 40 mitral clips, so really a revolution in mitral valve repair in some patients as well. This is a patient we treated a couple of years ago, actually. 86-year-old man from Salmon. He's a retired forester, an active fly fisherman. He's still quite active, independent, drives an F-150, has class 3 heart failure though that really limits his activity, and every night he has orthopnea. He has to sit up in a chair. He has severe degenerative mitral regurgitation and was considered high risk for open mitral valve surgery. Here's a transesophageal echo that shows a degenerative mitral valve with severe leakage across the mitral valve. He had severe mitral regurgitation and left atrial enlargement. And this is during the procedure. He was referred for a percutaneous mitral clip. There's a transesophageal echo probe here. We're fortunate to have excellent echocardiographers that basically tell us where to go in this procedure. And a transeptal puncture is required. We enter the right femoral vein and do a transeptal puncture. And this catheter is very bulky. And inside this guide catheter, there's a telescoping catheter called a clip delivery system. And this system can be adjusted antero-posterior, lateral, medial, flexion, unflexion. It's a very complicated 3-dimensional procedure. Here you can see the clip itself. The clip is made out of cobalt chromium, and it's made out of nitinol, and there's this film around it that accelerates endothelialization. I don't know if you can see these little tines here. They're called grippers. The grippers are what enable us to grip the valve leaflets. In this particular view, you can see the mitral clip is going from the right femoral vein across the septum into the left atrium, across the intraatrial septum into the left atrium, and then flex down towards the mitral valve. This is the posterior leaflet of the mitral valve. This is the anterior leaflet of the mitral valve. And the clip, we're trying to gather both leaflets with the clip. And once we gather both leaflets, we drop the grippers and pull the leaflets together to try and approximate them. This particular patient required 2 clips. It's not uncommon that we'll place 2 clips to repair the mitral valve. We placed as many as 4 clips, but with every clip you increase the risk of mitral stenosis because you're clipping the valve leaflets together. And so usually we place 1 or 2 clips, and this patient had 2 clips. Here you can see the 2 clips sitting side by side on echocardiogram, and there's only trace residual leakage. So he has flow around the clips and diastole and trace residual leakage during systole. So he had a nice outcome. And when we rounded on this patient the next day, he reported no orthopnea at night for the first time in months. So pretty neat. I just have 2 more quick cases that I wanted to show to emphasize some of the things we're doing in structural heart intervention. As I mentioned, this is really the area of closure. Left atrial appendage closure is coming down the pipe, but atrial septal defect closure has been quite routine for a number of years. This is a 64-year-old woman with exertional dyspnea. Echocardiogram showed right atrial enlargement and right ventricular enlargement and a small secundum atrial septal defect. This is a tiny atrial septal defect, less than 10 millimeters. This is an intracardiac echocardiogram. This is the left atrium and the right atrium. There's an intraseptal, this is the right atrium on top, left atrium on the bottom, and there is an atrial septal defect measured less than 10 millimeters. And so we chose this device. This is called a cribiform closure device, and this device has multiple fenestrations in it. It has a right atrial disc and a left atrial disc, and you essentially close the defect between the 2 discs like a hamburger. Working from the right femoral vein and across, this is the left atrial disc being deployed, and we pull the disc back against the atrial septum and try and keep it as close to the septum as possible. And then we push the other disc out in the left atrium, and it creates this hamburger effect where you've basically sealed the defect with a disc on either side. This is a fluoro of us pushing and pulling on the device to make sure it's not going to embolize. That would be bad if it embolized into the left ventricle, but it's quite secure. And then here the device is being released. There's a cable, and you just unscrew the cable and it releases the device. After the procedure, we do a bubble study where we inject agitated saline into the right atrium, and there's no bubbles coming across the defect from the right atrium to the left atrium. Last case is a 71-year-old man with aortic stenosis who had a bioprosthetic aortic valve replacement for aortic stenosis 4 months ago. It was actually about a year ago at this point, but 4 months prior. And then he presented with 100 feet exertional dyspnea and hemolysis. So he had low hemoglobin, low haptoglobin, high LDH, and was hemolyzing. He was found to have moderate to severe paravalvular leak on a surgically implanted valve, probably from a suture that had popped. And here you can see this eccentric jet. This is the left ventricle, this is the aorta over here, and this is the aortic valve. There's leakage around this valve. And he has what's called paravalvular leak around the surgical valve. This is a surgically implanted mosaic valve, and there is some leakage from the aorta to the left ventricle. It's kind of hard to see. So we're able to cross this leakage with a wire and then take a selective injection. You can see significant paravalvular leak through this into the left ventricle. There are several closure devices that are originally designed for closure of congenital heart defects, and this is one of them. This is the actual picture of the device that was implanted in this patient. This is called an Amplatzer ductal occluder device. It's designed for patent ductal arteriosus closure, but it was used in this case to close this defect. Here you can see the ventricular aspect of the device here and the aortic aspect of the device here. And then the device is released, and there was no residual paravalvular leak. In this patient's hemolysis stopped, and his symptoms resolved completely after this implantation. So a nice example of paravalvular leak closure. So final thoughts. Thanks for your attention. Interventional cardiology has really grown dramatically, certainly since 1977, and even in the 5 years that I've been here. Coronary, vascular, valvular, and structural heart intervention have emerged as fields in and of themselves. And I think that as we see more and more growth, percutaneous management will afford us to offer invasive therapies for patients that otherwise would be facing surgery or no therapy. So it's a really neat field to be a part of. Thanks very much.
I have 2 questions. The first is, you didn't comment on stroke risk after TAVR. What's the local experience with that? And if I understand it's low, which surprises me, and why is it low? But what do you quote to patients?
So I quote patients a 5% rate of major complications, and that includes either stroke or death or emergency conversion to open heart surgery or major bleeding. And I think that's about accurate. We had one patient with a major disabling stroke out of, I think we've done close to 190 cases. We have had patients, I think 2 or 3 with smaller strokes that were not disabling. And that's similar to the national experience now. In the original partner trials, the stroke rate with TAVR was 5%. But with the SAPIEN 3 valve, and I think with more operator experience and better delivery systems, that stroke rate has declined significantly. So I'd say 2% now for stroke with TAVR.
And what's the anticoagulation requirement after a TAVR or a mitral clip?
So with TAVR, we recommend a baby aspirin forever. If patients have atrial fibrillation, then we recommend warfarin, as they were on before. If they don't have atrial fibrillation, we recommend Plavix for 6 months after implantation. There are some patients who have myelodysplasia and low platelets or other bleeding problems, and we've implanted only with the baby aspirin. It's not really known what the best strategy is, and there are some people who think we should anticoagulate these patients with warfarin for 3 months post-TAVR. There is some recent data that suggests that there's leaflet immobility in a small fraction of patients that's related to valve thrombosis, not just TAVR, but surgically implanted bioprosthetic valves. So we may see that changing, but for now we do dual antiplatelet therapy for 6 months. And same thing with MitraClip, 6 months dual antiplatelet therapy. Yep.
Other questions?
Yeah.
TAVR's pretty cool to me.
Thank you.
About the only time that we're going to get involved is if it migrates. What's the risk of migration signs and symptoms in your retreatment for that?
The risk of migration is less than 1%. If that's going to happen, it happens in the cath lab. So we'll see it. There are case reports of a valve migrating later. Usually it's related to the valve being undersized. Right now, we implant TAVR in patients who have heavily calcified valves that anchor it, and we oversize by at least 5%, ideally. Down the road, we're probably going to implant this valve in patients who don't have as much calcium. For example, a patient who has severe aortic leakage and no calcium. And so we may see more embolization. But right now, we haven't seen any embolization outside of the cath lab. We've had a couple of patients where the valve is embolized into the aorta or into the ventricle, and the surgeons have had to bail us out. If it did migrate, then patients would be extremely sick, either stroke or heart failure or hypotension. Yeah. Right.
Thank you.
Thank you.